All right, good morning, everyone. It is 10 o'clock, so we're going to get started here today. Thank you for joining us on our virtual Zoom CEU. The title is Gray Matters, Understanding Depression in Older Adults. Hope you're having a wonderful, beautiful Minnesota day as we enjoy this weather we have coming up here. I want to introduce myself. My name is Christine Drasher. I am the marketing director for Emerald Crest and work with Cassia. And I want to share a little bit about the sponsor today, which is organized through our organization called Cassia. Cassia has many different senior housing options. As you can see there, we are mostly in Minnesota. I think we have just about 70 different communities within the 5 states, Minnesota being where most of them are, but we also have some locations in North Dakota, Colorado, Florida, and Iowa. As you can see there, we have a variety of different types of senior housing, and we also have a bunch of different services as well. Outside of senior housing, such as hospice, home care, pharmacy services, medical supply, and rehab services. So if you do want to get more information about Cassia, our website is cassialife.org. For today's presentation, we have featured sponsors that have put together today's speaker and event, and I want to just speak a little bit about them so that you have that information. We won't spend too much time on them because we want to get right to our speaker because she has a lot of great information. But I do want to just bring up and thank the following sponsors for putting today together. So our first one is Apple Valley Village. Apple Valley Village has independent assisted living, memory care suites. They also have connected to them a healthcare center that has skilled nursing, both short-term and rehab, or long-term, excuse me. They do have market rate and limited elderly waiver, caddy, and HUD in the housing. And then in the skilled nursing facility, private pay, insurance, Medicare, and Medicaid. As you can see there, I have their contact information along with their current availability, which is independent and assisted living 1- and 2-bedroom apartments for market rate. And then my community, which is Emerald Crest, we are exclusively memory care. We actually have 4 different locations, Burnsville, Minnetonka, Shakopee, and Victoria. We are specifically memory care in a 1-level setting, and we do a very unique staged model with looking at function and placing individuals in the different levels of dementia care. And then each of those staged homes have a unique program and staffing and approaches that they use for those different levels. We've been doing memory care for over 20 years. We do have market rate, elderly waiver, and caddy that we can take. And currently at all of the 4 locations, we do have private suites available for market rate, and we do have some elderly waiver at all sites. So if you do have clients that need that elderly waiver, just give us a call there and we will discuss what we have available. The Pines Senior and Assisted Living Community in Richfield is our next featured sponsor. They have independent, assisted, and care suites. They are mostly market rate, but do elderly waiver with a 4-year private pay requirement. And they currently have independent and assisted living 1-bedroom apartments available. So you can call them if you're interested in learning more. And then our next feature is Praha Village. Praha has been opened in 2019. They have independent assisted living and memory care. Market rate apartments, but they do have some limited elderly waiver and caddy for assisted living. Currently, they do have assisted living 2-bedroom apartments for market rate and 1 memory care, 1-bedroom for market rate as well. So their phone number is there too. The next featured is the Regent of Burnsville. The Regent of Burnsville has independent assisted living, memory care, and care suites. They are located in Burnsville, right off of Early Lake. They have market rate and some limited EW and caddy for assisted living. They currently have openings in their AL and IL 1 and 2 bedrooms and a care suite 1 bedroom. The Rosemount is our final location. It is independent and assisted living, memory care and care suites. They are connected right to the Steeple Center, which is a senior center in Rosemount, and they are market rate only. And currently they have AL and memory care listed here, but I just got a note that they also have a care suite available as well. So if you're interested in the Rosemount, you can call them as well. And then our last featured sponsor is Open Circle Adult Day, which is another service of Cassia. We have 3 local, or I should say metro locations, Apple Valley, Hopkins, and Heritage Park. And I know a lot of you are familiar with Adult Day programs, but they do have some current openings right now. Apple Valley does have a waiting list, but Hopkins and Heritage Park does have openings right now. And what's nice with the Adult Day services is they have not only private pay and medical assistance, but they also take VA benefits as well. I believe the VA, if they qualify, can get 2 days a week covered for Adult Day services. So give them a call if you'd like to learn more about that. You will get this information sent to you after today. So if you do have questions or want to look into any of these communities more, you will have their contact information. All right, so we are going to get going on our presentation today on depression. Our speaker is Kay King from NAMI Minnesota, National Alliance of Mental Illness. And Kay King is an adult community educator for the National Alliance of Mental Health in Minnesota, and is the Older Adults Program Coordinator. So we are going to allow Kay to now start sharing her screen. So we'll get over to hers. And then I just want to do a little housekeeping while she does that real quick. Just want to make sure everybody has their audio and their video turned off. And that'll just allow for us to have a nice clean recording at the end of this. So, all right, Kay, whenever you're ready, you can take over. Oh, you might be muted.
Thanks very much, Christine. Just want to make sure everyone can see a full screen.
Yes. Looks good.
Okay. Well, I'm delighted to join you. I never thought I'd be excited about Zoom. I've done so many classes on Zoom in the last couple of years, but on a day like today, works out pretty well. So thank you for joining us. I want you to see this first slide because we have a wide variety of classes available, and our website really is the key to finding out what we do. We do 3 things at NAMI Minnesota. We do education, we do support, and we do advocacy. We're not direct service providers. So I'm not a psychologist, which is a PhD. I'm not a social worker, master's level, typically someone like a licensed marriage and family therapist. I'm not a psychiatrist, which is a medical doctor that has a residency and internship in psychiatry. But we are really good with resources. I've been with NAMI 14 years, almost 15 years, and I have a passion for older adults, and I also have a passion for mental health and making sure that people have the resources that they need to connect others to the help that they need. So I'm an excellent first aider. I do teach the 8-hour mental health first aid classes that are taught nationwide, and I'll talk to you about those as one of our resources towards the end of the presentation. I really welcome comments in the chat as well as questions. And you have good resources too, because you represent, not just the metro area, but parts of greater Minnesota. And NAMI Minnesota covers the whole state. So if you'll put those in the chat, I'm going to stop from time to time and just ask Christine if there's any comments or resources or questions that are in the chat. So there are NAMIs in every state. So I work for the state office, which is located in St. Paul. And there's a NAMI Idaho, there's a NAMI Connecticut, there's a NAMI Florida. So take advantage of those resources, as well as you probably, have family members that live in some other parts of the country as well. When you go to our website, we do have some classes that are online still. We have certainly request form that you can request a private class. For example, yesterday, I taught a suicide prevention class in person for a charter school in Minneapolis. It was a work day for the teachers, and so they had a 4-hour suicide prevention class. This week, I'm also teaching, classes, but primarily online. That was just a fluke because they were booked a number of months ago before we knew we were going to have a snowstorm. The next information is how to reach me. And I'd suggest maybe writing down my email address. We have other staff that work with parents and teachers that are our children's staff. We have a suicide prevention coordinator. I teach some of those classes, but we have someone who coordinates that. We have folks that work with smoking cessation. So we just have a wide variety of staff that work on different topics of mental health and mental illness. So if you get in touch with me, I certainly can put you in touch with another colleague if I'm not the person. If you're in Greater Minnesota, you certainly can use our 1-888 number, and then also our St. Paul number, which is on the screen. And we each have different extensions. And I'm in the community a lot, so email is probably the best way to reach me. Today's topic is part of my Gray Matters series, and I have 5 programs that fall under that. And all of our classes have a paragraph descriptor that's on the website, so you can see if anything else matches. I do many, many classes for older adults themselves. I do classes for senior workers that work with older adults. And then, of course, I teach a variety of adult classes that are not older adult specific. I'm also a family member. So I was born to a mother who already lived with mental illness, and she developed bipolar disorder when she was a freshman in college. And my mom was at the University of Minnesota. And during her freshman year, she had a break from reality. And the word for that is psychosis. So psychosis is not a mental illness. It's really a symptom that goes along with some of the mental illnesses. So, you could have someone that lives with bipolar disorder that has psychosis, a break from reality. You could have someone that lives with schizophrenia that could have a break from reality. And again, that's called psychosis. You could have someone who has a substance use disorder of any age, and they could have a break from reality. So just want you to know that my mom had a break from reality. She had psychosis, and she actually then was hospitalized at Fairview Riverside Hospital. It's called St. Mary's then. And after a period of time, she got better and she went back to college. But she had a second break from reality while she was in college. And my mom was discouraged. She thought, something's wrong with my brain. I must not be cut out for college. And the year when she was first hospitalized was 1939. And there wasn't much to offer her in the way of treatment. So just want you to know that my mom went on to live to be 82 years old. And my mom lived a full life. I would say that maybe not totally the life that she had hoped for because she had an illness pretty young in life. But my mom and dad owned a restaurant in Le Sueur, which is where I grew up between Mankato and Minneapolis. And my mom and dad, besides owning the restaurant and both of them working in it, as did I, my mom also was a librarian in Le Sueur. And my mom, raised 2 children. I'm the youngest of 2. And when I was 7 and my sister was 15, my sister was diagnosed with the same illness as my mom, which is bipolar disorder. And today my sister's in her early 70s. She lives in adult foster care in southwestern Minnesota. And she's lived in adult foster care since her husband died. So she's probably been 18 years in adult foster care. And that's hard. You probably know that staffing levels in all healthcare are, totally inadequate. And that is true for adult foster care as well. About, a full year ago, my sister, adult foster care closed. And so my sister actually, after 18 years really in the same house and with some of the same roommates, housemates, I should say, needed to move. And it was hard to find a place. We kept her in the same city she had been living in, but it was hard. And even that house today has limited staffing. I don't know if you know this, but my sister lives in Mankato. Mankato, just 2 months ago, was identified as the city in the United States, not in Minnesota, the city in the United States with the lowest unemployment rate. And that's in all areas of work, but in the service industry and particularly in the healthcare industry, it's been pretty tough. My sister, luckily, is okay with me talking in a general way about her health. And so I do use some personal stories because I think they bring the topic to a greater focus. So we're going to talk about depression in older adults. And for purposes of older adults, I'm a boomer. I don't think people like being thought of as older adults, even at 65. But, the government, uses 65 kind of as their threshold for older adults. But as you know, some programs are 55 plus. You can start pulling Social Security at 62. But for purposes of this, let's say we're talking 65 and older. I'm going to give you a few mental illness basics. When I first wrote this program, this was the first of my Gray Matters series, I realized people didn't know very much about mental illness. I often ask people, how many of you had good mental health training in your 10th grade health class? And even if I'm speaking to a group of 20-somethings, I don't get very many raised hands. So a few basics I'll give you that are true for mental illness in general. And then I'm going to talk a little bit about risk factors and warning signs of depression and suicide in older adults. Talking a little bit about stigma, discrimination, they're different, treatment and recovery. I think one message I'd really like you to think about today is that people that live with mental illnesses, not just depression, but other mental illnesses, get better. There are exceptions to anything, but people by and large get better and live a life. And again, I mentioned my mom maybe wouldn't have chosen the exact life that she had, but she had a very full life. And when she died at 82, she did not die of bipolar disorder. Also talk about resources. Now, I'm always modest. I said, identify 3 resources to support older adults. You'll learn more than that. And I always say, if you don't learn more than 3, you're not trying. But I want you to share resources too, because I don't know resources in every city or every county. And I think your colleagues would be grateful, to hear about additional resources and things that have worked in your sphere of influence. I always smile that I have to even do this definition, but I find as I do my education, which I've done for 14 years, I just realize that sometimes people think that people have mental illnesses because they don't pray enough, or people have mental illnesses because they lead an unhealthy lifestyle, or that people have mental illnesses because they just are trying to be oppositional and make life hard for their family and friends. They really are medical conditions. And that's why we're the National Alliance on Mental Illness, not the National Alliance on Mental Health. We care about mental health. We think it's important to work on your mental health, but they're medical conditions. They're disorders of the brain. And they really disrupt people's thinking, feeling, thoughts, emotions, relationships with others, and the skills of daily living. Pretty comprehensive list, isn't it? I took biology late 70s for full disclosure, and I learned that my brain controls my heartbeat, my breathing, and then all these other things that I just mentioned. So I think of it really as the master computer board, of my body. The other concept that we talk about is integrated health. I mean, we all use the terminology, but our healthcare system often is treating people neck up and neck down, and we are interrelated. And so we're set up, unfortunately, not to look at the whole person. And certainly some practitioners do. There are exceptions to everything. But by and large, we're not set up that way. And, lots of our specialists don't talk to each other. Yes, we have medical records, but you're not always seeing someone within the same system. It's just really hard. So what causes mental illness? Now, I'd like you to actually use the chat, if you don't mind, and tell me what causes mental illness. And I've put 5 bullet points here, but those aren't the answers. So besides what's up on the screen, those are certainly contributing factors, but what causes mental illness? If you have a guess, put it in the chat, and I'll check and see with Christine to see what you said. And while you're doing that, I want you to know that there is an evaluation that I'm going to be sharing with you. And when you fill out our evaluation, it's electronic. And actually, Christine's going to put it towards the end of the program. She's going to put it in the chat function, and then she'll also email it to all the participants. But when you fill that out, it doesn't take very long. We will send you a certificate of attendance. And you can use that with your boards if you would like continuing education. And Christine will also talk to you a little bit about continuing education at the end.
Perfect.
And the other thing is that I do have a handout that I'm going to talk briefly about, and she's going to put that in the chat function also, and that's on crisis resources. Okay, so I'm going to ask Christine, anybody put anything in the chat of what causes mental illness?
We do. We have stress and trauma, abuse, neglect, and that's what we have listed.
Thank you very much. So I'm going to really answer the question, which is we don't know. Now, all the things that you said in the chat and all the things that I have up as bullet points, they're all true. I think what we're going to find out someday, this is Kay King's theory, is that it's multifactorial. It's not just one cause. No surprise there, because many illnesses that we know about are multifactorial. I'm going to take a drink of water, and don't forget to do the same during the presentation. So probably multifactorial, just like we already know that treatment for mental health concerns is also multifactorial. It's not just one thing that you do. And so the theory right now is you're born with a predisposition and something puts it in motion. And what puts it in motion is referred to as a second hit. So when you said abuse and you said trauma and things like that, those are definitely second hits. And don't forget COVID. COVID was a second hit. COVID is a second hit. Now, the theory again is you're born with a predisposition. There is no test to see if you have a predisposition. There's no blood test. There's no PET scan. There's no CAT scan. There's no x-ray. There's no urinalysis. And so, in my family, and I'm only speaking for myself, in my family, I know about 4 generations of people. And so in my family, about 50% of them have lived or do live with a mental illness. So going back to my grandma, she was the oldest of 10, grew up in LeSueur, Minnesota, and my mom is her daughter. But my grandma lived with mental illness, as did, 5 of her family members, 5 of her 10 siblings. And so 50% about in my family. Then my mom is one of 4. And so my grandma had 4 children. 3 of the 4 lived with a mental illness. My Aunt Florence did not. And they lived lives. They went to college, they had kids. And then my mom had 2 children. I'm one of 2. I'm lucky. I don't live with mental illness, and my sister does. My sister has 2 children, and one of my nieces lives with mental illness and one does not. So I just have to tell you, my family looks like a lot of heredity is involved, but that's not true for all families. You also should know that some of the mental illnesses have a little higher heredity component than others. Bipolar disorder, for example, is one of those illnesses, but it's not even 50-50% based on research. So good to know that heredity can play a part, but that's not the whole story. Just like you probably, when people say, well, how old do you think you'll be when you die? And you think, well, my grandma lived to be 80 and my mom and dad lived to be in their 90s, so I guess I'll be 80 or 90. Only about 30% of your life expectancy is related to heredity. The other 70% is environmental factors, lifestyle, all those things. So yeah, we all do that exercise of, oh yeah, well, my grandma lived this old and my mom and dad lived this old. But in actuality, that's about 30% of the determining factor for age and life expectancy. So you did mention some of these things, but I'll give you an example of something that is environmental. There's a type of major depression called SAD disorder. Seasonal affective disorder is what the acronym stands for. And we're at greater risk for it in Minnesota because of the latitude that we're at. So if you lived in Florida, Arizona, South America, Mexico, you would have a little less incidence of SAD disorder because there's more sunlight. There's a correlation between sunlight and SAD disorder. Not everybody in Minnesota develops SAD disorder. We all crave carbohydrates in the winter. We all kind of huddle in and want to stay inside. Not everybody, but we have this kind of retreat mentality. And we also hear people say, oh my gosh, if we have one more cloudy day, I'm moving to Florida. That doesn't mean you live with SAD disorder. SAD disorder is actually a diagnosable illness, and it has usually looking at a pattern over a period of time, it has usually a start in the fall, an ending in the spring, and it very much is related to the amount of light that you receive. There's also, some things that are biology related. So another type of major depression is postpartum depression, and about 20 to 30% of women who carry a baby develop postpartum depression. And just like SAD disorder, very treatable, but just know that it can be very serious. So it's important for people before they get pregnant or families before they have the baby to know a little bit about postpartum depression. so that, you can get the help that you need, and it is very treatable. So those are some samples, but just know we really don't know enough about the brain. And considering that it controls all the major components of our life, it would be great if we spent more research dollars. So when you look at dollars that are spent on major illnesses, mental illness does not even fall in the top 10 dollars spent for research. And I'd say it's a pretty important component of who we are. So how does a diagnosis of mental illness get made? Well, typically there's a cluster of symptoms that people have, and you need to report those to a health professional. What's taken into account is the frequency of some of those symptoms, how intense they are, how they affect your skills of daily living, how long those symptoms last. Those are things that are criteria that are used to make a diagnosis. And also the impact that any of those sorts of symptoms or any of those changes that people have on the person and their living in their life and their ability to raise children or go to school or to work. And volunteer work is included in that. It's really very important to have some caregiver or family input, and a good medical professional is going to ask for some of that. Of course, you have to have releases signed to be able to talk to family members and things, but oftentimes an older adult will have family members that get involved, maybe going to an appointment and things like that. And you can always give input if you're a family member, even if your family member has not signed any releases, you can always give information one way to the medical professional. And they can't share with you unless there's been releases because it's a privacy issue. HIPAA helps cover that, but you can always give information one way. And I just want to warn you, when you give information one way, the health professional may say, your spouse just told me the following information. So it's not going to be kept secret necessarily. The healthcare provider may very well say, I got this information from your daughter. And then know that initial diagnoses can change. And so our brain doesn't stop growing till 25, 26. Not that you don't keep learning after that, it's that growing. So the frontal lobe of our brain is one of the last things to finish growing. And that's where impulsivity lies. And so I always get kind of a smile out of people, and I do not want you to identify yourself, but how many of you have done impulsive things before age 25, right? Part of that is just, how we're wired. So it's really important to know that, yes, we do help young people that are struggling in relationships, or they're struggling in school, or struggling perhaps in a part-time job. We do certainly get help for them, and they may even be given medication. They may have talk therapy, all those sorts of things, but their brain could change. So they might be given an initial diagnosis maybe in their teens, and that diagnosis might change in their 20s. I wish it was a more precise science, but it isn't, and the brain is pretty complicated. So who can make a diagnosis of mental illness? Most of us go to a family practice doctor, or maybe a nurse practitioner, maybe a physician's assistant. I go to an internist, which is a specialty, but an internal medicine doctor. Some people do go to a psychiatrist, which is, again, someone who's a medical doctor that has gone on to have an internship or a residency in psychiatry, which is a specialty. A psychologist, most psychologists are PhDs. Some have been grandfathered in at a master's level. And so those folks can do everything that a medical doctor can do as it relates to mental illness, but they can't prescribe medication. And by the way, medication is not the only line of treatment. If you live with something called borderline personality disorder, know that borderline personality disorder, the first line of treatment is not medication. It is something called dialectical behavior therapy. And you may have heard of that as DBT. Also, number of different acronyms can be after a social worker's name, and those are master level, but I've given you some examples. So a licensed clinical social worker, a licensed professional clinical counselor, licensed marriage and family therapist, and you've seen those acronyms like LMFT behind someone's name. And I just want you to know that folks that have the L, including psychologists, can be licensed psychologists. I like having the L after their name. It means that they have supervised hours with someone who is licensed. And it also means that they have sat for board tests and passed those, and that they also are registered with their board in the state. And that way you can see if they've had any complaints and things like that about them by checking with their board. It's psychiatric nurse. You might see the acronym APRN, stands for Advanced Practice Registered Nurse, and you can be an advanced practice registered nurse with a specialty in psychiatry. And in Minnesota, you are able to prescribe medication without the supervision of a physician if you are an APRN. And those folks are great. My sister, for example, does see a psychiatrist, has for many, many, many years. But she also sees an advanced practice RN, and that person sees her a little more often than the psychiatrist does. They also can spend more time. They can bill longer periods of time. So they can be very helpful. My sister finds having both of them quite helpful. Physician's assistants cannot prescribe medication for mental health without the supervision of a doctor in Minnesota. So, you can have multiple disorders. That's true as you get older. I mean, think about it. I always smile because Betty Davis, very famous actress who won a number of Academy Awards. Betty Davis had a quote that getting old is not for sissies, and it really is not. So mental illnesses strike young, and I'm going to tell you how young. By age 14, about 50% of people who have signs and symptoms of a mental illness have them by age 14. That's often surprising for people. That figure rises to 75% by age 24. That just leaves about 25% of our population who might develop some signs and symptoms of a mental illness like depression after age 24. If you're going to have a break from reality, which is psychosis, right? We talked about when you have a break from reality, that usually occurs about age 25 or younger. So just know that being an older adult and developing a mental health concern for the first time in your 70s or 80s, pretty unlikely, especially if you take a good physical, psychosocial history. You'll probably find out that that person maybe had some bouts of depression in their 20s or in their teens or in their 30s. And then, they had lots of period or lots of years where they did not, struggle with acute symptoms. So just remember, being an older adult, you might think, well, wouldn't it be just normal to have depression as you age and you're getting near end of life? That's not normal. And usually with a good history, you'll find out they have had some other struggles much earlier. Now, people that live with depression or people that live with anxiety disorders are about 2 to 3 times more likely to have a substance use disorder. And it's not exactly cause and effect. Again, we don't know much about the brain, or wish we knew more. We don't know which came first, the chicken or the egg. I think you sometimes just guess that people self-medicate. You probably have heard that terminology. And maybe, I think you'd have to ask an individual to talk about themselves if that was true. But in actuality, we don't know which comes first. And what I do know, and I can tell you with a great deal of certainty, is that when you introduce other chemicals into the brain, into a brain that already is struggling, it just doesn't mix. It really does not mix to use alcohol when you live with anxiety or depression. Alcohol, which is the most abused substance by older adults of all the substances, is a depressant. So if you already live with major depression and now you're introducing a depressant into the system, just not good. There's other reasons why it's not good as well. Just know when Betty Davis said getting old is not for sissies, besides having a mental health concern that you've had maybe since you've been pretty young, then in addition to that, you might very well live with macular degeneration. You could live with diabetes. You could have had a stroke. You might have heart disease. There are other medical conditions. So you could have multiple issues as you age. And so these are young person onset, as I mentioned, and then you can have some other things that tend to go with a little older age. So it is really important. We try to do our best to control our weight, to engage with the community the best we can, to get regular checkups, to try to have a good diet, to try to exercise. But you still can develop Alzheimer's, which is a disorder of the brain, but it is not a mental illness. And probably I should talk about that for a moment. One way that I can sort of make a distinguishing point about brain disorders is that you can have, for example, a tumor like a glioblastoma. It's a cancerous tumor of the brain. Now, certainly that's a brain condition, but it's not a mental illness. You can have dementia, neurocognitive disorder. We usually use the word dementia, those of us that are lay people. And so Alzheimer's is the most common of the dementias. And it's not a mental illness. It is a disorder of the brain. You could have a traumatic brain injury, maybe because of sports that you played younger, maybe because of a fall on the sidewalk or just a fall. And a traumatic brain injury is not a mental illness, but it is a disorder of the brain. So you sort of see where I'm going with this. Epilepsy, it's a disorder of the brain, but it is not a mental illness. But some of those other disorders of the brain, depending on how they're affecting the part of the brain where the brain injury is, or where the stroke was, or where the tumor is, can affect certain functions of the brain, like speech or impulsivity and things like that. So it could look like a mental illness, but generally speaking, those things I just talked about are not mental illnesses, but they are disorders of the brain. Another analogy would be maybe your pancreas. So diabetes is unfortunately, pretty serious in our population, and that's a disorder of the pancreas. You can also have pancreatitis. Now, pancreatitis is not the same as diabetes. And you could also have pancreatic cancer, very serious type of cancer. That also is not the same as those other two illnesses, but they are all illnesses of the organ called the pancreas. Just like I've told you, these other things are disorders of the brain. Hope that's helpful as an analogy for you. So the most common of the mental illnesses are anxiety disorders. Now, this chart is not older adult specific. And I'm sorry to report that there's ageism going on too. We just don't have a lot of statistical information in general about mental illness, and we have even less with older adults and mental illness. So I just want you to know that what you're looking at is all adults, not just older adults. But anxiety disorders, even in older adults, are the most common. And you can see in a given year, they're about 3 times more common than major depression. Now, I started by writing, this program on depression, but I have one on anxiety disorders too, but do know that it's about 3 times more. Substance use disorder, and that I'm going to define that for you. That is misuse of prescription drugs. That's misuse of alcohol, mostly for older adults, but misuse of street drugs, misuse of prescription drugs, and misuse of alcohol. And so that substance use disorder, about 8.1, that's pretty high also. And then bipolar disorder, which I mentioned is the illness that my mom lived with and my sister does live with, about 2.8% of the population in a given year. And eating disorders, those also are a mental illness. There's a range there because we don't have really very good stats, but I want to make sure you know a couple things. First of all, the most common of the eating disorders is binge eating, but you maybe have heard of bulimia and anorexia, and those are eating disorders as well. And this is an important point to note because we think eating disorders are just among the young, and chances are maybe that first started in that time frame because most of mental illnesses start young, but eating disorders certainly can continue with you as you are an adult and as you are an older adult. And eating disorders are the most fatal of the mental illnesses. And I'm going to repeat this, it's really serious. Eating disorders are the most fatal of the mental illnesses because anorexia, for example, affects a whole system and typically causes heart problems that often are fatal. So it's really important to get help for eating disorders. And we're lucky, I think, in Minnesota because we have 2 programs that have inpatient and outpatient eating disorder programs. One is Melrose Institute, and the other one is the Emily program. Now, I don't know all programs in all of Minnesota. I wish I did. But if you have eating disorder programs that you're aware of that are in your geographic area of the state, besides the Melrose program and also the Emily program, please put those in the chat because others would appreciate knowing about those. Schizophrenia, because of the nature of your work, I'm guessing the people that came to this today work in housing with services, work in case management, work in perhaps some other healthcare fields. So you're going to see greater incidences of schizophrenia or maybe bipolar disorder than the general population. The figures you're seeing on this chart are general population. It'd be like going to a Vikings game and you looked across the sea of people in that audience, this is kind of the breakdown that you would see. And that's a big enough sample, by the way, using a stadium. But if you are in housing with services or in law enforcement or in county case management or in housing with services, you're going to see larger incidences of these illnesses because people need services. That's why they're engaging with you. But schizophrenia in a given year is less than 1% of the population. It's not that common. And then when you add the top figures up, they should equal 100% because this is US adults in any 1 year that live with a mental illness. That should equal 100%, and it does not. So when you add these up, the reason that it doesn't add up to 100% is you can have more than one. So you could live with an eating disorder and live with anxiety disorder. You could live with a substance use disorder like alcohol, and you could also, live with schizophrenia. So just know that besides that, then as you age, you can have lots of other health conditions. So I think Betty Davis was on to something. Now I'm going to talk about this slide, but then I'm going to stop again and just see if there's any comments or questions in the chat. And if you had an eating disorder suggestion, put that in the chat as well. So sadness and grief are normal. If you've lived long enough, like I have, I've lost my parents. I've lost my grandparents. 3 of them died before I was born. I also have lost my best friend from childhood. She died by suicide. I have lost jobs. Maybe some of you have lost marriages. So I have to say that sadness and grief, that's normal. It's a normal human condition. And they're usually temporary responses. Not that you won't miss a spouse or partner that passes away. I ran a retirement community where 4 of my residents, not at the same time, but 4 of my residents lost their children, adult children, during the time they lived there. And 4 of them had already lost their husbands. And now they had lost a child. And the child was 55, 60, and my residents were in their 80s that lost their kids. And they said to me independently, each of them said it was harder to lose their adult child than it was to have lost their spouse or partner. And I'd never really thought of that before. I mean, it made me kind of have to pause and really think about that. So it's not that you don't have sadness and grief that continues. It's just that typically they're temporary, and in some period of time, and it varies by person, you get back to your skills of daily living. You engage maybe again in life. So it is natural to feel that grief, and that could be a grief of something that is a person or a relationship, but it also could be a house of many years. I think our well-meaning children or nieces and nephews or friends, want us to downsize because then we don't have to deal with the snow, and we don't have to deal with possible falls, and we don't have to, worry about our older adult in our family. But it's not leaving the physical house so much as leaving a community. And that might mean, my hair doesn't look so great today, but I'm saying, that's your hairdresser that you've had many years. That's the medical people and dentists and things that you've used for a lot of years that you really like. And your family's encouraging you to live closer to them, like come and live with us in the Boston area. And can you make friends? Sure. I'm an extrovert. Sure, I can make friends. But I have to say that it really is difficult. It's harder in life. You're not as mobile. Maybe you don't drive anymore. You might have hearing loss, so it's hard to join a music group that you used to do when you were younger. So that can be the loss as well. And then loss of health. My mom's sister, my Aunt Florence, she died at 94, and she was a health professional. She was a head dietitian at St. Mary's Hospital in Rochester during her career. And I have to say that when she started having health issues, which really her tipping point was about 90, she really was very healthy. She was shocked. She was really shocked. And she didn't live with depression or any other mental health concern, but I really did see some anxiety develop at that time. Now, she lived in her own home until she was 92 and lived in a care facility for the last 2 years of her life. The other thing is that, typically normal sadness passes, not totally passes, but untreated depression does not. They're different. And while we're talking a little bit about grief, it's important to know some grief resources, and they don't all have to be faith-based, but we're lucky in Minnesota. Many of the grief support groups are through faith communities, and if that fits for the person that you're trying to help, that's a place that you can look to as well. Sometimes your grief is because you've lost someone to suicide. And so there's different grief groups for people that are suicide loss survivors. SAVE, which is a national organization based in Minnesota, they're a pretty good resource if you lose someone to suicide. That's a little different grief. And so just know that if you have good grief resources, different than depression, please put those in the chat function because people appreciate getting resources. So I'm going to just stop and ask you the question, anything that we should talk about at all, Christine?
Yeah, we have a question from Becky Allard. How do you describe the difference between psychosis and delirium?
Okay. Now, I always have to give you the disclaimer. I'm not a health professional, but I will tell you, you can read a little bit. I mean, you can certainly go to a website that you trust to look at it. But delirium typically has sudden onset. And delirium, I'll use Aunt Florence as an example. I actually spoke with her one evening at about 10 o'clock at night, and she was at the time in her early 90s. And I got a call the next morning. I talked to her at about 10 o'clock, and she lived alone. I got a call from the emergency room at the hospital, St. Mary's, that she was in the emergency room and that they asked me, does she have dementia? And I said, a little bit of memory loss. She's part of the Rochester Mayo Clinic dementia study. She'd been in that study 10 years. And I said, a little bit, but not really. And I just talked to her at 10 o'clock and they said, well, she pushed her pendant and we picked her up and brought her to the hospital and she is not oriented to time, place, anything. And she said she had fallen. She was on the floor in her living room and she had lots of bruises and things like that. And they, I guess, anticipated maybe that she had been on the floor probably about 8 hours maybe. And they did that because they had a creatinine level that they could take, I guess. And so based on that, they determined she'd been on the floor quite a while before she pushed her pendant. And so they have a delirium room, which is at St. Mary's Hospital in Rochester. And I told them that it was not normal for her to have this disorientation. So they determined, even though she was 90 some years old, that they would place her in the delirium room. And there is some research that shows that the delirium room, which she was there about 4 days, they orient you to time, place, they make sure that you stay awake during daytime hours. They asked me an extensive list of questions so that they could talk to her about family members and things like that. And she actually reoriented. So delirium is typically sudden onset, and that's usually what makes it different. My Aunt Florence did not have depression and did not have been diagnosed with it, nor did any of us notice anything like that, but the fall really did cause her to have delirium. So that's about all I can tell you, but I would encourage you to read more about it. And there is such a thing as delirium rooms. The only one I'm familiar with is the one at St. Mary's Hospital in Rochester, but it was very helpful. And my aunt went on to live, another 3 years and the delirium passed. Anything
Great.
else that you see?
I don't see any other questions. So if you do have a question, please type it in there now. I do want to mention I did throw in the chat that resource on the crisis resource handout. I threw that in there to everybody to access as well. But so far, no questions. So I think we can move on.
Okay. And do know that we're going till 11:30, just so you know. So take a look at this picture and you can see that it's raining. There's a woman on the other side of a pane of glass. She looks older. And I'd just like you to give me some words that would describe that picture. So if you put in the chat some words that would describe that picture, and Christine's just going to summarize them. She'll say, oh, quite a few people said this, quite a few people said that. So just put some words that describe that picture.
All right, we have lost, lonely, distant, sad, bored, empty, foggy, distraught, hopeless, couple more sad and alone and bored. Some really good answers.
Well done. And I'm going to throw in a couple more. There's a pane of glass between her and us. And so I think, isolated. And can you see that her eyes, it's a little hard to see, but you can see her eyes are not focused. There's maybe middle distance that they're looking. And so, and you can see maybe, looks like her hair is not well kept, maybe could use a shampoo and, head and hands, right? And so the reason I asked you to do those words is that when you go to the doctor or you're talking to family or friends that are close, you're probably going to use words like that. I don't think people are going to say, oh my gosh, I'm depressed. You might say, oh my gosh, if we don't have any sunlight. Saying that you're depressed doesn't mean you live with major depression. It's a terminology thing we say. or you might say, oh my gosh, I'm so anxious about this test. That doesn't mean you live with anxiety disorder. You're using that word kind of interchangeably with how you're feeling. So it's important to know this, and we're just going to talk briefly, not very much, about some signs and symptoms of major depression. So what's important to note in all the things that we're going to look at is that it's a change for that person. So if you're kind of the cup half full person in life, and you're starting to look at things kind of as the cup half empty, that's a change for you. So you're not comparing yourself to others, you're really comparing changes that you're having or things that family or caregivers notice that are different. By the way, I don't think we often think of anger as a sign and symptom of depression, but it is, somewhat socially acceptable to be angry at a certain level. And so for men, maybe that are struggling with major depression, maybe it comes out as anger. Irritability, don't look at that by itself. You're looking for a cluster. As I mentioned much earlier in the presentation, you're looking for a cluster of symptoms. And I don't know about you, but during this last 3 years, I've been a little crabby. And I'd say I've been irritable. I've said I've had to apologize a few times to family and friends for being short with them, right? But if someone by and large, is not helpless, I don't think you met me just for a short period of time. I'm not by and large a helpless person, and you probably have a sense of that. So that would be a change for me. For someone who is typically not had some trouble with making decisions and there's some indecisiveness, that might be a change. If there's some confusion, that might be a change. If someone has some thoughts of suicide or talks about death, and not just end of life making plans for that, because we should all do that. But I'm just saying, if you see some of these changes, a red flag should go up just to have a discussion with the person. I care about you. I love you. Here's what I've noticed. Or if you're a caregiver, you might share that information not only with the resident themselves, but you might also share it, with the family or the person that they've designated. So, when I ask older adults, if you had some memory issues or concentration issues, would you call your clinic and say, give me the next available appointment? If somebody cancels, get me in. And they all shake their head. And I'll say, well, why not? Why wouldn't you get in? And they'll say, who wants to hear that you have Alzheimer's? Because Alzheimer's is fatal. Right now, we don't have anything really that slows it down, because you've probably lived with symptoms about 10 years. So taking a medication, probably you'd have to start it much before you have that tipping point, where you see some of those symptoms. Now, someday we are probably going to have some preventative information. Someday we're probably going to have some treatment and things like that, but it's fatal right now. So who wants to get that diagnosis? So people just say, well, I can't do anything about it anyway. And I really encourage people to get in, because impaired memory and concentration can also be a side effect of other things. So, including major depression. And major depression is treatable. So obviously, if they do a battery of tests and determine that, cognitively you don't have a dementia, in fact, you have major depression, I'd be like, woo! I'd be really excited, because it's treatable. So I just encourage you and those that you care for and those that you love, that you have them get in and really have a good physical. And, those that are trained to be able to diagnose something like Alzheimer's, they're pretty accurate. They're over 90% accurate, according to the Alzheimer's Association. They have to be trained clinicians. And the battery of tests is not just, 3 screening questions. It's more than that. But I just say, get in. Now, untreated depression, and this is not just older adults, this is of any age. Untreated depression is a really high risk factor for suicide. Untreated, the keyword is untreated. So obviously, as a first aider, I want to be the bridge to connect people to the help that they need. I want people to feel better. And most people do, including when they live with major depression, with help. Crying, nothing wrong with crying, but if it's a change, if it's someone that typically does not use that to express their emotions, and that's a change, just pay attention. It could be that someone who's been sober or clean for a long time is now starting to use again. At the very least, that should just get a discussion going. Honey, I love you, and I see that you're using alcohol again. What's changed? What's happened? Tell me more. So it gets a discussion going. And then, of course, you want to, again, be the connector to getting them some help. It could be personal appearance changes, but that could be other things as well. And I'm going to actually use my mom as an example. So my mom lived independently a pretty long time, and it didn't always make me feel very comfortable because some of the period of time that she was still at home, I was living in Aruba and did not have easy access to see how she was doing. So during that time, I had others watching out for my mom, including, an informal arrangement with someone that helped her with her finances and also checking in regularly with her. So I came home on a visit and I saw that my mom, her hair wasn't well done, and I had set up a standing appointment at the local salon. And, she looked like she hadn't washed her hair. She also had some staining on her clothes. And so my mom lived with bipolar disorder, and some of that has a component of major depression. So I thought, well, is that going on? I also thought of her vision because, my mom had just though gone to the eye doctor, and the eye doctor in my hometown is my high school classmate. And so turns out my mom's vision was fine. So then I was trying to quiz her, like, what's going on? And my mom knows I'm a bossy girl. And so my mom didn't want to show any vulnerability because if she did, she was pretty sure that I was going to make her move. And actually, my mom was mistaken. I wanted her to stay at home as long as she could. But through some questioning and a little bit of pushing, I found out that my mom didn't feel comfortable going into the basement where the washer and dryer was. And I'm glad she didn't feel comfortable. She rarely wore her pendant, and it wasn't safe for her going down the basement stairs. So once we determined that was the problem, mostly, then, I helped her get a stacking washer and dryer. And somehow she thought, I was going to force her to move. And that wasn't the case. So don't look at just the obvious and jump to conclusions. It is really important to engage the person that you're talking with. And sometimes you get pushback, believe me. I was raised by a mother who already lived with mental illness, and I have lots of colleagues and friends, and I've tried to help, right? And I sometimes get pushback. That's a story for another day. Physical, this is the kind of stuff we tell the doctor or the nurse practitioner when we come in. We talk about sleep problems. We talk about maybe that's why they weigh us. Maybe we've lost weight, or maybe we've gained weight since our last appointment. And, loss of appetite for some people might look like depression. For others, it's overeating. We're all different. And I love talking about constipation. I'm sorry, but I just do. If you went in to your doctor and talked about constipation, I'm pretty sure that they would not start talking about your brain. I'm pretty sure they would ask you about how much fluid are you taking in? What kind of foods are you eating? How much fiber? And in that little 15-minute appointment, that's about all you're going to talk about. So don't look at constipation and say, oh my gosh, I've got constipation. I must have major depression. It's a cluster of symptoms that you're looking at. The other thing you should know is that, people that live with migraine headaches, about half of them also live with major depression, and vice versa. So I want you to know that don't start diagnosing people that have migraine headaches in your life. Doesn't mean that they all live with major depression, but there is a correlation. And obviously correlation is different than cause and effect. But this is the sort of things that most people bring into their medical appointments. They don't always talk about the other changes that they've had. Some other risk factors of depression. I don't think there's any surprises on this list, but the last one, do not underestimate being a caregiver. And for some of you, that's personal caregiving, but for some of you, it's part of your job. And so that's a really high risk factor. So we have to take care of the caregivers also. It's really trite, but the analogy of put your oxygen mask first on yourself before you turn and help the person in the seat next to you applies as it relates to this as well. If you've had depression other times of your life, you're at a little greater risk than the general population to have another episode, maybe older in life. And stressful events, we've had those. I can't tell you how much stress. We've had contentious elections. We have Ukraine. We have people starving in Ethiopia, starving. And that went to the back page of the newspaper because of things like Ukraine. Inflation is skyrocketing. Yes, I'm a white middle class woman, and so maybe it isn't affected my life except hurting my pocketbook a little bit. But for some people who are living paycheck to paycheck, this has been horrendous. And there have been a lot of things. Think about Turkey and think about Syria. I mean, it is overwhelming what is going on, in the United States right now, and what has gone on for some people that are older adults in their lifetime, such as World War II and other things like that. Some other things, poverty, when you don't have shelter, when you're unsheltered, and you are living in the throes of poverty and can't meet your basic needs, very, very stressful. So that can be that second hit. And you also could have other medical conditions. We've talked about some of these a little bit earlier. There shouldn't be any surprises here, but don't forget side effects of medication. All medications have side effects. Even, an over-the-counter baby aspirin has side effects. So it's important to talk to your doctor about those. And if the doctor or the nurse that works with the doctor doesn't spend some time on it, then involve a pharmacist, because they certainly understand side effects and interaction of drugs. So with mental health, especially when you live with really severe mental illnesses, it's really good to have a pharmacist on your team. When my sister's had to be hospitalized for other medical conditions, because she has had some surgeries and things like that, I always try to have a pharmacist on the team, because she takes some mental health medications. She takes 4 of them, in addition to things that she takes for other health conditions. So it's really important to have a pharmacist on that team, which I have to ask for. They don't automatically do that when she's been hospitalized. Now, suicide, I'm only going to point out, you're probably thinking, well, why is this 2019? Because our US government has not certified the figures yet for 20, 21, and 22. And so I can tell you some basic figures for beyond 2019, but these are the certified figures. So that's why I use them. So just know that a suicide rate in the United States, it went down in 2020. I mean, it's like a miracle. And for 20 years, it's just been rising. But in 2020, the first year of COVID, it went down. It's like people like me who educate about suicide prevention, we were thrilled. But we already have some preliminary figures for 21, and we also have some preliminary figures for 2022, and they've gone up again. So it's been a very stressful time. And, I'm not sure why in 2020 they went down, but they did. Now, I just want you to know that the rate for suicide is highest in middle age. So government defines that as 45 to 64. That's the highest rate, and that still is the case. The second highest rate is older adults, 65 and older. And the rate, again, these are 2019 figures, but they're certified. So for 15 to 24-year-olds, that is the third highest rate. Now, during this pandemic time, suicide rates have been really jumping for 15 to 24-year-olds. But they're still highest among middle age, and they're still the second highest for older adults. So it's not the stats that I care. You don't have to remember these figures. Just remember that older adults are high. So it is important for you to have a suicide prevention class if that's where you work. And you came to this because it's on older adults. So I really recommend some suicide prevention training. Now, I'm just going to give you a figure. So for deaths by suicide, in 2019, it was about 47,511. And in 2020, and that's a firm figure, 2020, it went down. It went to 44,834. So that is for the United States. But for every person that dies by suicide, the estimate is that 25 people attempt. So we want people to get some basic training in suicide prevention so that you can be the bridge to connect people to the help they need, so that we don't have attempts, which can cause permanent damage or shorten your lifespan, nor should we have those deaths. I don't believe that we're ever going to get suicides down to 0, but wouldn't it be great if instead of 47,000 people dying, we lost 20,000 people? And I think with training people like you and me, I think we can make a difference. These are rates from Minnesota. And if you want more information about suicide statistics, the Center for Disease Control keeps the national statistics. And for Minnesota, our Minnesota Department of Health keeps our Minnesota statistics. So the 2020 figures that are shown here are preliminary because they haven't been certified yet. But you can see that, and I'm going to call out the colors because not everyone can use color matching. But the bottom line is kind of a turquoise blue, and that represents women. And the navy blue line, which is on the very top, that line is total suicides in Minnesota. So you can see in 2020, just like nationally, they went down. We don't really know why yet because there's not been enough research, but they went up again in 2021, at least the preliminary figures. The lime green line, which is the middle line, is men, and men are a much higher rate of suicide than women. And it's really because lethal means that they use. It's unfortunately that gap is getting smaller because women now know how to use firearms as well. That's a leading cause of death by suicide in the United States is firearms. And men typically knew how to use firearms more than women, but that's changed because when you're in the military and more women are in the military, you learn to use weapons. Also, in Minnesota, we have hunters that are men and women, so you learn to use firearms and take classes. So just know, and there's lots of firearms for permit to carry. In Minnesota, of course, you can get a permit to carry and learn about firearms and for protection, for example. So again, the turquoise bottom line is women in Minnesota. The middle line, which is kind of a lime green, is men in Minnesota. And the top line is total recorded suicides in Minnesota. So enough of those statistics. I'm not going to go through the warning signs of suicide. I really want you to take a suicide prevention class. I mean, you certainly can take a moment to look at the slide, but I want you to take a longer class that really is suicide prevention only. I told you yesterday I taught a class, and I'm going to tell you a little bit about that class. But untreated depression is a really high risk factor for suicide. Untreated depression. Again, these are some warning signs. You only need one. You know, certainly if you have more than one, greater risk, but you only need one. So you need to know some basics about suicide prevention. I'm a suicide loss survivor. I have lost my best friend from kindergarten. She died 12 years ago. I've lost an uncle to suicide also, and I've lost a coworker to suicide. And I've worked a long time. I may have even lost other coworkers, but certainly one that I was working with at the time. So it's not uncommon. It's just we don't talk about it very much. So I have a passion for teaching suicide prevention classes. I already told you the gender difference. More men than women die by suicide, and it's primarily because of the means, firearms. I've told you a little bit about age, but previous attempts are also a high risk factor. But you'll learn these sorts of things if you take a suicide prevention class. Not everybody who attempts or dies by suicide lives with a mental illness, but it is a higher risk, especially if it's an untreated mental illness. I'm going to say that again. Not everybody who attempts or dies by suicide lives with a mental illness, but it is a higher factor than the general population, and especially if it's untreated mental illness. So these are the classes I want to talk about. So QPR is so accessible. We teach it online at least twice a month. I teach it, stands for Question, Persuade, Refer. It's for anybody 16 and older to take, general class for the public. So it's easy to access, it's free. You can have a class at your private workplace. Maximum number of people for QPR is 30. Safe Talk is what I taught yesterday. It's a 4-hour class. Living Works of Canada wrote it. And it's again for people 16 and older, but it's more robust. It's different than QPR. They complement each other. QPR is from the QPR Institute, different organization that sponsors that class. I teach Safe Talk, I teach QPR. Safe Talk, we have a grant right now that for sure goes through June 30th. We've reapplied from the Department of Health for a continued grant, July 1st forward. We don't have that yet, but we have some money still available for Safe Talk classes. It's 4 hours, 30 people maximum. So if one of you would like to have a class of 30 people for your organization, get a hold of me. Assist is a 2-day class, again, general public, but it's 2 full days. So if this is a topic of interest to you, Assist is by the same organization as Safe Talk. Calm is a means restriction class. We also have funds that we still can do some Calm classes. It's for health professionals. So it's learning how to restrict the means, because when people have a crisis that includes suicidal thoughts, they go home to you. The average length of stay in a mental health unit is about 3 nights. So people go home to you and you need to learn how to keep them safe. So we want health professionals to learn how to keep people safe and then be able to communicate that to whoever the person goes home to. So if you go home to a nursing home, the staff there needs to keep you safe. If you have suicidal thoughts and you go home to assisted living, the staff there needs to keep you safe. If you go home to your parents need to know how to keep you safe. If you go home to an apartment with 2 roommates, the roommates need to know something about how to keep you safe. So we need health professionals to do some coaching at the clinic, coaching in the emergency room, coaching as an EMT or an EMS. So a means restriction class like Calm is really important. So we have some funding right now. So if that would be of interest, it's 30 people maximum. The others, all these have paragraphs on the NAMI Minnesota website that explains them, but take advantage of our grant. Now, you heard Christine say that she put in the chat a handout, and it's 2-page crisis resources. I'm not going to talk about the whole handout, but that is golden. That handout Spread it to the world. You don't have to keep it secret. You don't have to just keep it for yourself. And make sure that some of the numbers on that 2-page handout make it into your phone. These are the ones I want to call out because they're maybe the most crucial, but there are excellent numbers. For example, there's a Black, Brown, and Indigenous 24/7 helpline. You know, you might want to, when you're in crisis for mental health, not just suicide, but crisis in general for mental health, you might want to talk to someone who looks like you. And so that 2-page sheet that was put in the chat is going to give you lots of resources besides the one on this slide. The other thing is, just know that Christine is also going to email that out if you can't pull it out of the chat. So you know that in July, I hope you know, in July last year, a 1-800 number was changed to a 3-digit number. So much easier to remember. So if someone is in mental health crisis or has suicidal thoughts, they or you, as someone who's trying to help them, can dial 988. It's a 3-digit number, just like 911 is for law enforcement, 988 is for mental health emergencies. And it's national, it's 24/7. You can call it, you can text it, there's even a chat. So if you haven't memorized 988, put it in your cell phones, please. I mean, I beg you, please. There's a national crisis text line. It's been around maybe 6 years, and it's 24/7. And some people feel more comfortable reaching out by text. And so it's 741-741. And we want you to put Minnesota in the message because the responder who's going to text back, we'd like them to be a Minnesota responder. Because as you know, all states have different mental health systems. So even if you're in Hudson, Wisconsin, and you're using Wisconsin resources, they're different than they are in Minnesota. We have mobile crisis teams in Minnesota. We're lucky. So 87 counties, they all have a mobile crisis team. And you can reach the mobile crisis teams on your cell phone, only on your cell phone, doesn't work on a landline, **274-747, and you have to use the stars. Now, some mobile phone plans don't let you use that number. So don't wait till an emergency to test it on your phone plan. So it's **274-747, and just call and say, I'm just making a call to test this. I don't have a mental health emergency. I just want to check and make sure it works. Okay. We can't, of course, the mobile crisis teams can't go to every place. They have to triage. And so some of their work is done by phone, but they're 24/7. And if you want a list of all of the landlines for each of the counties, you can get them on the individual county websites. So let's say Candy-Ojai County, you can actually go to the county website and look up their crisis number on their website. Or to the right at the bottom, you can go to DHS and they will give you a list of all 87 counties and the landline for each of the counties. So my sister lives in Blue Earth County. So I have *274-747 in my phone, but I also have Blue Earth County's mental health crisis number. Now, today is not the day, but there are some times when you would use 911, but I tend, if it's not someone with a weapon, because someone might have a weapon because they're going to attempt suicide and they have a loaded gun, I would call 911 because even if you call the mobile crisis team, they're going to have law enforcement accompany them if it's going to be, a mobile call. So I just want to make sure that that's a longer discussion, needs to be a longer class. Not everyone's comfortable calling 911, maybe from a cultural standpoint. But if you do call 911, you need to say, this is a mental health emergency, ask for a mobile crisis team, or you'd ask for a CIT trained officer, which stands for crisis intervention trained. And it's officers, both sheriff's deputies and as well as police officers that have had 40 hours of mental health training. All people that have gone to the police academy before they apply to work for a law enforcement agency have had some mental health training. Some have had a few hours, some have had a little bit more. Their police department or their sheriff's department has more training, but the gold standard is the 40-hour CIT training. And officers want to have the training, it's costly. And so there has to be funding in the county or in the city for that to happen. Now that was very short, but take a look at that crisis handout and then make sure at least these numbers get into your phone at the very least. Okay, I'm going to stop and see if there's any questions at all, Christine.
No questions at this point, but if you do have a question, please do put it in there. I did have somebody throw into the chat to everybody a resource, Rogers Behavioral Unit for Mental Health Clinic in Eden Prairie. So that is a resource if you need it as well.
Yep. And I'm not sure, I don't know every clinic setting. First of all, you should always make sure your insurance covers a clinic setting. But if that's Rogers Memorial, if you know someone who lives with obsessive compulsive disorder, or they maybe have a substance use disorder and obsessive compulsive disorder, those are some specialties that Rogers Memorial has. And they have an inpatient and outpatient facility in Wisconsin. And they've pretty recently open facilities here in Minnesota. And I'm guessing that Eden Prairie one might be Rogers Memorial, but I don't want to jump to conclusions there. But obsessive compulsive disorder, is its own disorder, and they're good at it. And they also are good at substance use disorder, sometimes co-occurring with that. So thank you for that resource.
Yeah, and somebody did confirm that you are correct. It is Rogers Memorial. Yep.
Thanks. Their large facility is in Wisconsin, but I'm thrilled that they came to Minnesota.
Yeah.
So what can help when you have major depression? For older adults, I didn't put medication first because that isn't always the first line of treatment. It is when you first get diagnosed. So in other words, talk therapy and medication are the first line of treatment when you're first diagnosed with major depression, both. So if you went to a doctor as an older adult and they just gave you a prescription for medication, like an antidepressant, I'd be running from that doctor, because the first line of treatment for major depression when you're diagnosed with it is talk therapy and medication. Doesn't mean forever for either of those modalities, but they're very helpful. Now, if an older adult has memory loss when they're first diagnosed, talk therapy is not going to be very helpful. Doesn't mean talking isn't helpful, but talk therapy doesn't work when there's memory loss. So then maybe they'd just be given medication. But talking, certainly in relationships with people, are helpful, but not necessarily the therapeutic talk therapy if you have memory loss. Education is really important, and just reducing stigma and discrimination. Now, the next bullet point, when you look at all those things that can help when you have major depression, I don't know about you, but you do that for anything. You do that for cancer. You do that for MS, multiple sclerosis. You'd even do it with a fatal illness called ALS, Lou Gehrig's disease. So my point is, it's the same sort of things. There's some additional things, like I put peer support specialists. That is for people who have lived experience with mental illness and they're stable. They can apply to the Department of Human Services to become a peer support specialist. And if they're accepted, they go through a 2-week training program. And after satisfactorily completing that program, they can receive peer support specialist designation. And there are jobs out there for people that are peer support specialists. So that can be a career path to getting back into the workforce. And for example, People Incorporated is an organization that provides direct mental health services, and they have peer support specialists on their staff. I know 2 churches in Minneapolis that have supported financially having a peer support specialist shared by the 2 churches. And one's a Catholic church and one's Lutheran, but that peer support specialist has worked in both congregations, and it's a paid position. They just shared the part-time cost of that person. So just know that the other things on here, they're all important for a healthy life, including a life that includes your mental health. So no surprises there. But for a diagnosis of major depression, the first line of treatment is medication and talk therapy both. Now, Minnesota Council of Health Plans like Blue Cross Blue Shield, Medica, those are the kinds of organizations that would belong to the professional association called the Minnesota Council of Health Plans. And among their members, so this isn't the general population in Minnesota, this is their members, 10% of their members that are 65 or older have a mental health diagnosis. Obviously it's greater than that in the general population, but that's what they report in the health plans. Those folks take an average of 3.5 psychotropic medications, which are the kinds of medications you take for mental health. And they might take many other medications as well. And then older adults that are 80 or older in these health plans that belong to this association had the highest rate of mental illnesses. So just to give you some comparison, but again, this is not the whole population in Minnesota. This is members of plans like Blue Cross Blue Shield or other care organizations. Now, I think this is a very hopeful slide. Over 80% of older adults, remember 65 plus, diagnosed with depression can be effectively treated. That's a lot better than odds in gambling. So I have to say that it's never too late to get help. Are you always cured of a mental health concern? Not always. Some people are, but it's really important to get the help you need. Could be something else. You know, sometimes an underactive thyroid looks like major depression, and underactive thyroids are very treatable. And usually it's with medication. And quite frankly, there's not too many side effects of those medications. There are side effects. So it's really important that folks get in because it could be something else. You know, it does matter how we talk about mental illnesses. I've been trying to model it the whole time, such as, you know, I said my mom lived with bipolar disorder. You can't go wrong if you say lived with, manages, experiences. My sister experiences bipolar disorder. I don't say my sister is bipolar. My sister is not an illness. She's a mother, right? She's a giving, loving person. She's all those things. You know, when you start thinking about tombstones, right? And you think about what do you want on your tombstone? You know, you have your birth date, you have your death date, and you have your name. And if there's room for anything else, is that what you're going to put your illness? You know, am I going to say K. King, Lou Gehrig's disease? I doubt it. So I think it's really important to remember that the items on the left side, those are the words I used when I wrote my mom's obituary, right? She was all those things. The things on the right are sometimes the stereotypes that we hold. You know, if we're crossing the street because someone is gesticulating and also talking to themselves and we're scared, I don't think talking to yourself has any really problem with anything that has to do with violence, right? But what message does it send when you cross the street that you don't want to associate with them, or you don't want to help, or you don't want to recognize them as a human being? So I think you have to think a little bit about, you know, where do we get these stereotypes? And we get them a lot of times from the media. You know, it doesn't make a very interesting TV show, you know, on one of the Law and Order kinds of shows, or CSI kinds of shows, to show someone with mild anxiety disorder, because that's not very much drama. So just know that illnesses are on a continuum. People can have mild anxiety disorder, moderate anxiety disorder, really severe. You can have mild bipolar disorder, moderate bipolar disorder, really severe. My mom lived a life, but she also had to manage an illness, not severe, but moderate to severe, from age 18 till she died at 82. Now I want to talk about resources with our remaining time. So I'm just going to talk about a few. There's many. I wish there were more, but there are many. So NAMI has family classes, and they've been taught for more than 35 years. I have taught NAMI's family to family class for 16 years. I'm actually going to be teaching in March, and it's an 8-week class. It's taught nationwide. So if you have family members that live in California, they can take the very same class in California. So I just want you to know that, you know, my class isn't full yet. I have 3 spots left. So if you're a family member and you have availability, it's 2.5 hours for 8 weeks in a row. You know, take a look at our website and you'll see family classes. And tell your family members that live in other states. It's a really solid class. I teach it above and beyond the 50 hours I give to NAMI for paid work. I do this above and beyond that. It's really a solid class. We also have a class called Hope for Recovery. It's only taught in Minnesota. It's 3.5 hours. It's some basics about mental illness. It is from the family perspective also, but anyone can take Hope for Recovery, but you have to be a family member to take the family to family class. So look at our website for that. It's not specific to older adults, but it is really helpful because you probably have older adults in your family that live with mental illness. But for the family to family class, you do have to be a family member. Mental health first aid. I've taught adult mental health first aid for 15 years, and it's taught internationally, started in Australia. It's taught in every state, and it can be taught online. It's pretty long online, but it's a full day class. And in person, if you feel like COVID is flattened enough for you, you can certainly schedule a mental health first aid class. 30 people maximum. There are 2 books for every student, so there is a fee for that. NAMI just wants to break even. We have teachers that teach it. I also know people that teach it with other organizations. So the teachers may not be affiliated with an organization, because you can be a teacher and have your own business if you want to. There is an older adult version, and that also is a full day. It uses the adult mental health first aid books, but then it has additional materials that are specific to older adults. And I teach the older adult version. I teach the adult version. I also teach a youth mental health first aid, which is for adults that work with youth that are 12 to 18. Really great. So you can go to mentalhealthfirstaid.org and you can learn more about mental health first aid. DHS, it's a pretty dense website, a little hard to navigate, but they have lots of resources as well. People Incorporated is a direct service provider. Volunteers of America, they do a number of things, not just with older adults, but they do have some specialty in older adults. So they run some nursing homes. They have some therapists that have some specialties in older adults. The community mental health centers around the state, and I've given you a couple examples. Canvas Health, which is in the East Metro, Hiawatha Valley Mental Health, which is in the southeastern part of Minnesota. There's one in Fergus Falls. There's one in International Falls. Not enough, but there are community-based mental health providers at those centers. Senior Linkage Line, I bet all of you know about it, but sometimes they'll forward people to me that are older adult mental health questions, but they're pretty knowledgeable and they keep their database up to date. They can help with lots of things related to older adults, not just mental health. They're whizzes at Medicare. So if you have Medicare questions, not just related to mental health, they really know a lot about that. A really good resource. So there is this older adult mental health first aid. And again, if you're interested, 30 people maximum, best in person, but the mental health first aids are authorized to be taught online. And so that's a possibility. You certainly could reach out to me if you want more information. But in the United States, mental health first aid is handled by the National Council on Wellbeing. They're based in Washington, D.C., and part of their mission is mental health first aid. So it's a good resource, National Council on Wellbeing, and mental health first aid falls under their umbrella. NAMI has a national office in Washington, D.C. They have good resources, but I really recommend you look at Minnesota resources because each of the state Minnesota chapter, we're probably one of the more robust in the nation. We're a smaller population state, but we have many, many good resources. Our executive director is Sue Abderholden, and she's been with us 21 years, and that has helped. We've had a lot of stability, and she is really excellent with legislative advocacy. So the legislature is in session right now, and during these 21 years, her fingerprint is on much of the legislation, not by herself, obviously, but a lot of her fingerprint is on many of the bills and changes that have been made in the mental health system in the last 20 years. The National Institute of Mental Health, you might know it as NIMH, it's a government agency. They have lots of good information. They used to print materials, but now everything's on PDF form. But if you go there, you can learn a lot about research. You can learn quite a bit about the illnesses. And also at NAMI, we have fact sheets on most of the illnesses also. That National Council for Mental Wellbeing, that's one of the things they do is the mental health first aid courses, but they have so many seminars. I must get an email, 3 times a week from them that just talks about resources. SAVE is local. They're based in Bloomington. They do have suicide loss survivor groups and resources for groups. And so again, that's a little different going to a grief group when you lose someone just because of natural age. That's also hard, but SAVE has some suicide resource groups for people that are survivors have lost someone close to them to suicide like I have. So these are some resources as well. And this is being recorded, so you have these resources. If you are trying to find a psychiatrist or trying to find a psychologist, check your insurance, of course, but you can also use their finder tools. So the Minnesota Psychiatric Society is a professional association for psychiatrists, and the Minnesota Psychological Association is a professional association for psychologists. SAMHSA is a government agency. I also really like what they have. They have some older adult specific material, and that stands for the Substance Abuse and Mental Health Services Administration. Lots of good resources from them. Area agencies on aging, the one in the metro area is called Trellis, but they are grouped by county clusters. So you probably have an area agency on aging in close to your area. For substance use disorder, there are a couple of programs, not enough, but Senior Recovery Program is the East Metro. Silver Sobriety is the Lake Elmo area. The Retreat has an older adults program, and that's located in Wayzata area, which is the west part of the metro. You may know of some in your area, but senior specific is not enough, not enough. Jewish Family Service of St. Paul, I'm calling them out because you don't have to be Jewish and you don't have to be in St. Paul. So the reason I want to call them out is that they have a program called PEARLS. And PEARLS is an acronym, Program to Encourage Active and Rewarding Lives. And know that it's evidence-based practice. It was not started in Minnesota. And they have grant money so that if you know an adult, and they can be in greater Minnesota also, they don't have to be Jewish, that's 55 plus, they can be screened to see if they're eligible for the PEARLS program. And they use things like devices and things to be able to talk to people or the phone. So Tara Burns is on my advisory committee, and she's the program coordinator at Jewish Family Service of St. Paul. So take advantage of that if you know a senior that's struggling. Maybe they haven't been diagnosed with depression, but they can be screened by Tara or one of their staff to see if they're eligible for the PEARLS program. And right now they have grant money, so take advantage of that. Inpatient, there are some units that are older adult specific. We just lost, in downtown St. Paul, we've closed St. Joseph's Hospital, and that had an older adult mental health unit. We lost over 100 beds of mental health beds. They're going to, UM Health Fairview is going to open something next to Regents Hospital, not too far from there at the old Bethesda site, but it's not going to be ready for more than a year. And meanwhile, we've taken beds that are desperately needed. And those took out some older adult beds as well. So Fairview Riverside has older adult inpatient, Centracare in Monticello, Regina and Hastings is Alina United Hospital in St. Paul. Now, the older adult does not have to be in an older adult specific unit, but they would be seeing a geriatric psychiatrist. And the bodies are different. As you age with mental illnesses, they're different. So there are very few geriatric psychiatrists, and most of them just work with the units that are in hospitals and don't see individual patients. And I'm done with my time, but I'm going to go a couple minutes over. So if you need to leave, just know that the evaluation link is going to be sent out to you in addition to being in the chat function. And I'm going to take another 2 minutes. So thank you for joining me. If you need to leave, sorry, I'm going a little bit over, but I have a lot to say. So Friends and Company is formerly Little Brothers Friends of the Elderly. If you have older adults that you work with that are lonely, which is pretty common, they have a coffee talk program. If you know older adults that would like to volunteer, they can be trained to be in the coffee talk program. But it's an opportunity to call in and you connect with a volunteer. So if you know older adults that want to be volunteers, it's a good program. And also people that are lonely and would like to talk. So just contact Friends and Company, and it used to be called Little Brothers Friends of the Elderly. So we have a NAMI walk, we do legislative advocacy, we have a helpline, which is during business hours. We're not a crisis line, but we're good with resources. So you certainly can refer people to us during business hours, and we'll get back to folks pretty promptly. Take a suicide prevention class. I highly recommend it. We have booklets and fact sheets that you can read on our Minnesota website, lots of classes. And if you want our newsletter, you can sign up for that on our website. And if you want to join our legislative committee, those are all things you can do. We have volunteer opportunities, all those sorts of things. Here's my contact information, my initial K and then king@namimn.org. And I just want to really thank Liz and Christine. They contacted me a while ago to do this class, so I appreciate it. And I'm going to turn it over to Christine.
All right, thank you very much, Kay. Great information. If you have any questions, please put them in the chat. We'll try to get to them real quick here. But while we're kind of talking through some of these links that were sent in the chat for you, what we need you to do. I know, Liz, you have this, or Kay, excuse me, you have this NAMI survey that you would ask everybody to do. And I know it will give them a certificate of attendance, but there's also another reason why you want them to do this, right? Does it have to do with grants with NAMI?
Yeah, we apply for grants regularly. And so we use the data, not identifying anyone, just to share how many people we've talked to and what sort of feedback we get. So if you can, be very grateful if you'd fill that out.
Great. So that's listed there on this slide. I also put it in the chat room. Also, if you need a CEU, if you could go in and complete this link as well, this will be how you can receive the CEU. The CEU will then come out probably within, I'll send it via email to those who complete this probably within the next week or so. And then I want to also mention here our next CEU that Cassia and those featured sponsors are putting on is actually next week. I can't believe it's March next week. But our next one is on professional grief. And we have Nancy Lloyd from Grace Hospice talking about as professionals in healthcare, you know, how can we reduce fatigue and burnout, that type of stuff. So I hope that you're able to join us for that. I think this goes hand in hand with our talk today. So the link is here to sign up for that CEU. It is Zoom as well. And I also put that in the chat. All right. So, all right, Amanda asked for the link and it's in there for you. Thank you all for joining us. You will see an email from me in the next week with a link to the video along with handouts that I reviewed with you and some other information probably within the week. If you have any questions or need anything specific, my email is listed there as well. But for all of Cassia, and all of our featured sponsors, I really am thankful for you all to join us today, and I hope that you'll be able to join us next week as well. So thanks again, Kay. Great information, and unless you don't have anything else, I think we're done. Thanks, everyone. Have a good day and stay safe.